We're rolling. Hi everyone, this is Nurse Kristen back at you again. I know it's been forever, about 6 months or so since I made my last video, and I told you guys that I would make a video about like home health and how it all works and what is the RN's role as a home health nurse. So I finally have time to make the video. Just quick FYI, I am in the process of moving and relocating with a new job and a new place to live, and I'm completely moving out of my area that I've been in for a while. So just getting busy with that. But I guess I can update you guys on that in another video, I guess. But this video is what is the RN's role as a home health case manager. Now, as I told you guys in the last video, a case manager out in the field is a registered nurse that coordinates care between all of the disciplines. So he or she would coordinate care between the different therapists, speech, occupational, and physical, as well as coordinate care with the LPN if the LPN is going to be following you after you start the case, and then you're just doing supervisory visits. And then if the patient needs help with ADLs or activities of daily living and personal care, then you would also implement a home health aide in that situation. So basically what happens is the patient comes out of either the hospital or comes out of like a rehabilitation center, and they're not completely 100% well. They still need care in the home setting. They're not completely recovered yet, not 100%. So we're kind of here, or we're there to bridge the gap between the acute care or subacute care setting and their well-being or their complete. We're basically there. I'm trying to find a good way to say it. We're there to optimize whatever functions that they have left. Okay, that's the best I can really come up with to say. So come in. I usually work a Monday through Friday week. That's not always true. Usually I'll work every other weekend, and then the weeks that I work the weekend, I'll have the 2 days during the week off. So it's kind of alternating weekends, if you can understand that. So I'll start with the start of care. We are bringing a patient into our services. We actually call it a client. It's not really a patient, it's a client. When we admit a client into home health services, we get something called a client order. And here's an example of one. I have blacked out any identifying information because of HIPAA, of course. But it'll have things like the name, like demographics. So it'll have the patient's name, the address, their age, their Medicare number, their closest of kin, like an emergency contact, the doctor that ordered the home health, because all patients that are on home health require a doctor's order. A doctor has to write an order for home health, and they have to specify what type of home health. Do they want skilled nursing? Do they want physical therapy for muscle strengthening and gait training? Do they want occupational therapy to help with activities of daily living? Or do they want occupational therapy to help with like feeding, or what's another good one? How to bathe themselves. Occupational therapy is could do that as well. And then home health aid kind of, like I said, bridges that gap. If they're still kind of debilitated after they get home or not optimal to where they can bathe themselves, then the home health aid usually steps in, comes in anywhere 2 to 3 times a week for like 2 or 3 weeks, just to kind of bridge that gap when the patient gets home. Anyway, what else? It will have their diagnosis, of course, and if the patient is, say, like a wound care patient, they should have wound care orders. The doctor should write wound care orders on the client order sheet here, what he wants done. If there are no orders, then the nurse case manager has to call the doctor's office for orders. And So we basically do what's called, I deal with mostly Medicare patients, so we do what's called an OASIS. Any Medicare patient that you're admitting, which most of the agencies that I worked with were strictly Medicare. Some agencies do Medicare and insurance, but mainly the ones that I do are Medicare patients 65 and over generally. And you do what is called an OASIS. It's a start of care paperwork for this patient. It's federally mandated. You have to do it. It has to be done. It has to be done by either a registered nurse or a physical therapist. In most cases, pretty much all cases, a RN is the one that does it, unless it's a physical therapy only case. If the patient is getting straight physical therapy, there's no nursing involved or any other discipline, then the physical therapist can do the admission. But in general, they like the RN to do all the admissions pretty much. So we do that, and then we set the frequency. So based on what the patient is exhibiting, based on their diagnosis, we will give them an approximate frequency of visits. So say a patient has come home from the hospital with a CHF exacerbation. That particular patient has a very high chance of being rehospitalized in the next few days after they've been discharged. So we will have a nurse, either the registered nurse case manager will follow the case through to the end, through discharge, or the RN will do what's called supervisory visits. So that'll be admissions, discharges, recertifications, which you have to recertify a patient after 60 days of being on service. If they need care beyond 60 days, then you have to do what's called a recertification so that they can continue to receive home health services, and that's a Medicare requirement. And then also resumptions of care. Resumptions of care are instances where you're basically having to do another OASIS after a patient has been hospitalized. So say the patient comes home, has an exacerbation, has to go back to the hospital, and then comes back home again. That's when you would do a resumption of care. You're basically resuming the care that the patient was receiving before they went into the hospital. So also, there's just so many instances. It's crazy. Usually, the RN case manager will have anywhere between. Usually, the agencies will do what's called a point system. An RN is expected to have anywhere, depending on the agency, between 6 and 8 points a day. But usually, OASIS visits are worth more than a regular visit. Regular visits are worth 1 point. Say it's a wound care visit, or an insulin visit, or you're just teaching about the disease process, just doing a teaching type visit. Those are worth 1 point. But if you have an admission, that's usually worth 2 points. If you have a recert or a resumption, those are usually worth 1.5 points. And if you have a discharge, depending on the agency, that could be between 1 point and 1.5 or 1.5 points. So the RN is expected in her day to get between 6 and 8 points. So that could be 3 admissions could make it your whole day because they're worth 2 points. So if you get 3 admissions, that's 6 points. That can make your whole day. Or you could have straight visits worth 1 point. That means you have to make 6 to 8 regular visits. Then we have what's called high-tech visits. High-tech visits are wound vacs. And if you don't know what a wound vac is, it's basically for people that have hard-to-heal wounds. Diabetic ulcers, chronic venous stasis or arterial stasis ulcers, non-healing surgical wounds. I'm trying to think of anything else. But basically, wounds that are very chronic and hard to heal. They would be a candidate for the wound vac. And requires a doctor's order, of course. And you basically it's a machine that is attached to a medicated foam that is cut to the shape of the patient's wound. So it's cut and fit to the size of the patient's wound, and it's placed in there, and then you secure it with a tegaderm, or that's what I call it, a tegaderm. It's probably another name for it, but that's what I call it. It's a see-through sticky dressing that goes over it. And then it comes with a hose that's attached to it, and the machine has a hose that's attached to it, and you connect the two ends, and the machine uses negative suction to draw out all the ook and gook and crap out of the wound. And it's supposed to facilitate and expedite the wound healing. So that's considered a high-tech visit when you have to put on a wound vac, because usually patients on wound vacs have to have it changed, have to have the foam dressing changed about 3 times a week. Usually is what it is. So that's considered a high-tech visit. High-tech visits are usually 1.5 points. Another example of a high-tech visit is a IV. We do administer IVs at home, and so that's considered a high-tech visit. And that's usually worth 1.5 points. Trying to think of what else. So yeah, basically, an RN case manager can be paid by the point system, where they're paid by the amount of points that they get, or they're paid a straight salary. Usually in my case, I'm paid a salary. Depending on the agency, you have a certain amount of points that you have to meet per week. So you have daily and you have weekly goals. Usually, like I said, depending on the agency, it's between 6 and 8 points a day. And then also, depending on the agency, it could be anywhere from 30 to 35 points a week. And then anything that you make over your expected weekly amount, you get paid at the per diem rate. So whatever their per diem rate is for RNs, anything that you make over that point system, over the 35 or 30 points a week or whatever it is, you get paid a per diem rate. So there's an opportunity it's an opportunity to make very good money doing this. If you're expedient and you know what you're doing and you manage your time well. Time management is so important. Flexibility in home health, very important. Your schedule can change on a dime. They can add patients to you. They can take patients away. They can expect you to go way on the other side of town or in another county, and you have to be willing to do it. Point blank, period. If you don't like sudden changes, or if you're not very flexible, or you don't like to travel long ways, then you don't belong in home health at all. You're going to have all different types of personalities. That's anywhere as a nurse. You're going to encounter people that are mostly great, but you're going to have people that suck. And that's just all there is to it. And you have to roll with the punches with that. Supervisory visits on the LPNs and the home health aides. I believe it's every 30 days for the LPN. So you have to go where the LPN is for your patient, the patient that you're managing. And you have to do a supervisory visit just to see how well they're doing. Do they seem competent in what they're doing? Are they dressed well? Are they professional with the patient? And yeah, so you're doing a supervisory visit on the LPN every 30 days, and then on the home health aide every 14 days, every 2 weeks. I'm trying to think of what else. So, like I said, if you like to be autonomous, and that's another thing, let me point out, you have to be autonomous. Like, you have to be able to think quickly on your feet and have confidence in your decision making. Don't second guess yourself, because you have to make decisions in a split second. So if you are a person that is very not very confident in your decision making, or you second guess yourself, you probably need to work in a hospital or a nursing home or somewhere where there's people that you can bounce ideas off of or go to when you have a question, because in home health, it's just you out there. The office, yeah, of course you can reach them by phone, but when you're in the patient's house, you're it. You're the eyes and ears of the agency, and you're the eyes and ears of the doctor. If there's anything untoward, if a patient has a 200 over 110 blood pressure, you got to call. Actually, that would be grounds to just call 911 and have them sent out to the hospital. But anything, you have to be very good at assessing, and that's basically it. Good at knowing subtle signs that patients exhibit in their home that is cause to call the doctor and let him know, even if he isn't concerned about it. It's good that you cover your ass and call the doctor anyway, and then document that you called the doctor and let them, that you're covered, and what the doctor said or whatever. You just constantly, like anywhere else, cover your ass. But in a nutshell, that's basically it. I could go on more, but this video is already 15 minutes long. It's so detailed and complex, but it's a great job. And believe it or not, home health nurses tend to make more than nurses in the hospitals and things like that. People don't realize it. They're like, oh, well, what do you do? Like, what does a home health nurse do? Like, what do they do? And so I'm hoping that I shed a little bit more light on what we do. It's still even more complex than that. I'm just giving you like kind of the tip of the iceberg. But basically, like I said, in a nutshell, we are the coordinators of the patient's care in the home setting. And that's basically what we do. So, like I said, sorry it's been forever. I know I said I was going to make this video a long time ago, and now just getting to it. But I made it. So there you go. What else? And that's basically it. Like I said, I'm in the process of moving, big life changes going on with me. I hope to catch you up on it in another video. And that is about it. So I know that a lot of you guys are and I still watch YouTube videos. So I know that a lot of you guys that I follow, nursing students that I follow, have graduated, and congratulations. It's a big feat. And all you have to do now is conquer that NCLEX beast, and you are golden. And then I know a lot of you guys passed your semesters, your respective semesters, so congrats about that. And I will look forward to seeing you guys in another video. All right? You guys have a good evening, and Happy New Year. All right, bye.